Hi guys and welcome. Hi Gillian, thank you so much for joining me.
Good afternoon, Anna. It's lovely to be here.
It's so good to have you back. It has been far too long since we've had you with online pet health, and I'm really excited about today's topic because it's something that I really care about, but from a academic perspective instead of necessarily from a practical perspective, I find it quite hard to implement. So today we are talking about outcome measures and how we're incorporating them into our equine practice. And I think there's been so many fantastic developments in the research in the last few years that we have quite a lot to talk about. So I'm excited. Guys, if you're listening, if you're joining us live, welcome. It is so good to have you. We have Gillian Tabor with us today. We would love to be talking with you. So please ask questions, join the conversation. We would love to know how you are using outcome measures, where your biggest challenges are, all those wonderful things. So join the conversation. Gillian, will you please introduce yourself? Let us know a little bit more about who you are and your interest in outcome measures.
Oh, thank you, Anna. Sort of how long have you got, really? I can go back quite a while. So yeah, for anybody that doesn't know me through the webinars that I've fortunately been asked to do with you guys, I'm a physiotherapist. My background is that I trained the human route first because I've been doing this a little while, and that was the only route when I started. I decided that I wanted to do this prior to my A-levels and my university here in the UK. So I sort of set about the pathway. And so since graduation, I've undertaken some postgraduate studies, and I now work as the programme lead for the MSc Veterinary Physiotherapy at Hertfordshire University in the UK. Alongside that, I've got my own practice. So I work in the southwest of the UK. I mainly see horses now. I see the odd human if they moan at me enough that they want to be seen, and a few sort of clients' dogs as well. But I integrate that in with the teaching and the research that I do. And as a note, you've already mentioned a little bit of my theme, a little bit of a geeky area that I have is around these outcome measures.
Yeah. So I think when you first introduced yourself to us a couple of years ago, you said that you were kind of known as the back lady. But I must be honest with you, I'm getting like the outcome lady vibes in the last couple of years. It's really where your research has been focusing. So yeah. I love that. Yeah.
But it's not just the last couple of years. When I started the whole reason this came about was because when I did my master's in vet physio, and I did that at the Royal Vet College in London, I wanted my dissertation to be on the measurement of core stability. How good was core stability, rather? Could we do core stability with horses? Because I'd taught my human patients. I used to do the back school when I worked in the NHS, and we did mat work exercises, and we talked about your manual handling and lifting and how to use your core. So I wanted to do that with horses. So I thought, right, yeah, this is what I do. And then I sat down with my supervisor and we went, well, that's lovely, but how do we measure it? And that was where it all started. And that was in 2001 that it all started.
Okay. Yes. I think we have, I often have that question as well. How do we actually measure that? And it's less of an issue when we're in clinical practice, huge issue when we are in academia. But it's actually not such a little problem when we're in clinical practice. So talk to us about why it's so important for us to have and use objective outcome measures. And maybe also what are objective outcome measures, because it's actually really, really broad, the amount of outcome measures that are available. So there could be some confusion around that. It's not just one thing.
So I guess basically the principle is to try and remove the subjectivity with regards to actually evaluating what we're seeing. So the challenge I think we have in clinical practice is that we all want our patients to get better. We all put in whatever intervention it may be, and we're hoping that we've moved our patient from point A to point B along their pathway to recovery or maintaining function. And so we are heavily invested in our outcomes being positive, and that leads to bias, and that bias can be conscious. So in the good old days, there's this talk of these snake oil salesmen, they just put something that was, just an innocuous substance in a jar and sold it to you, telling you that it would fix everything. So that's conscious bias. That, that's very deceitful, and that, I hope nobody's in that game. But there's also this unconscious bias. So it's been studied in all different professions, with medical, human medical, physiotherapy, and also, in vets when they're looking at when they've used diagnostic analgesia, the before and after. If they've been told it's had a certain intervention, then it might, you might think that it is improved. So what the idea of outcome measures and objective measurements is that you are looking to try and remove that subjectivity. So you want it to be as objective as possible. And by being objective, you're going to be using quantifiable data. So say you took a measurement of a size of something, it was 12 centimeters and now it's 14 centimeters. You can see, the change, and that can be documented. And then you can document, the time that you took the measurements, what happened before or after. You can go into the detail. And the idea really is to use the most reliable and the most valid outcome measures that we have got. So, the idea being that there are obviously those that are very lab-based, very research heavy, and they cost a lot of money. You've got an MRI. MRI is very reliable. It's repeatable. It's valid. But obviously we can't put a horse through an MRI, but we could put a small animal through it. But I don't have an MRI. I'm not sure about you, but not very many people do. So that is a good gold standard system to use, but it isn't very field accessible. So sort of part of the journey that I've been on is trying to look at some of these tools that we can use actually in clinical practice, and sort of studying them and sort of developing them and seeing whether we can actually create useful metrics that we can use in the field.
I love that, because it is a problem. And so much of, even in the equine industry, some of the objective outcome measures that take that subjectivity out are just not accessible, like force plates and IMUs, more accessible, but not to everyone. And that makes it really tricky for us to really get behind it. But what it comes down to is that if we don't have an objective outcome measure, we can't evaluate whether or not our treatments are effective, which interventions are effective, which ones are most effective. And then, so how do we call ourselves evidence-based practitioners if we don't have that? Okay, so let's look at some of the different outcome measures that we could be using or should be using in clinical practice that are applicable and that are practical.
Yeah, okay. So there are sort of different types, really, and I've sort of interchangeably using the word objective measures and outcome measures. But if we sort of look at the strict definition, and this, really does show the nerdy side of me, if we're thinking about an objective measurement, we are usually thinking about a single discrete measure of something. So if we look at range of motion, we use our goniometer, and we've got some papers. I'm going to cite them. That sounds really sad. We can put a reference list of them later. I can summarize that and pass that to you. But we've got some papers that have looked at the repeatability of the same person using a goniometer on repeated times, or different people using the goniometer on the same limb. And that has been shown to be both reliable and valid. And as I'm saying that, do you want me to go into the sort of background of the research, the difference between reliability, validity, and?
Yeah, I think let's define that at the outset, and then
okay. Okay, so reliability is all about the ability to repeatedly measure the same thing again and again. So if I take my goniometer and I measure it at 55 degrees, when I go back, it should be 55 degrees, 55 degrees. So if one person's doing that measure, that is called intra-rater reliability. So that's within one person. But if you and I take that goniometer and we both get 55 degrees, then that is inter-rater reliability. So that's the reliability but reliability is different to validity. And that's something that I find a lot of people, when they talk about measures, they get a little bit confused. So an example I give is, if you're trying to measure lameness in a horse by the colour of its head collar, we can be very reliable to say, yes, that horse has got a red head collar on, it's got a blue head collar on, therefore it's lame or it's not lame. But that's not valid. What we need is a measure that is both reliable and valid, because the validity is its ability to measure what we are actually wanting to measure. So you have to choose a tool that is both reliable and valid.
And that sounds really obvious, but often it's not that obvious, right? Yeah. Whether or not the tool we're using is actually measuring the thing we want it to measure. That is often a problem. Yeah.
Yeah, it is. And it is, I know I used a bit of a silly example there, but if you were measuring the effect of let's say sort of a manual therapy on the cervical spine, and you wanted to look at its effect on gait. So would you measure, range of motion? Would you measure speed? Would you measure stride length? Would you measure symmetry of the horse moving? All of those factors, you have to decide, where you're going down that route, because actually, there's so many variables along that pathway, and each of those have a measurement. So we could measure sort of a global score, or if we like the example of a goniometer, we measure a single discrete measure. But so long as we know what we're choosing and how we choose it, and another example of an objective measure might be using a flexi-curve ruler to look at the thoracic profile of the epaxial muscles. Absolutely brilliant for a saddle fitter to measure change in the dimensions. But for us, as in the rehab field, what we would want to know from that is how much of that change is to do with muscle dimension change, how much is it to do with fat, the adipose tissue, the thickness of the hair, or is it a postural change? We know of the horse, when they go up into a little bit of a flexed thoracolumbar spine, they change their profile. So it's not saying that measure isn't reliable, but knowing what part of that is valid to the question that we're asking is important. And then, so those are sort of a few of the objective measures. What else have we got? We've got a pressure algometer as well. That is a tool that's been used in lots of research. Really, quite good reliability, certainly very good intra-rater. So one person repeating again and again. The challenge that we have with that is, I don't know how many of us palpate our horses that way. Do we go in with our fingers and go along the spine? So it's very good from a research point of view, but is it that useful for clinical practice? That's something that we have to evaluate. And then on the other end of the scale, from the objective measures, we've now got our outcome measures, and they have sort of historically been, in human practice, patient-reported outcome measures. So I could tell you with my pain score, how many times or how many steps I can do before my knee hurts, or how far can I walk. And there are also then the things like the timed up and go test and the sit to stand test, and they're all very patient sort of dictated metrics. It doesn't need me to tell you that our animals, our horses, can't actually tell us exactly what we want to. So we have to have a proxy for being able to report those outcome measures. So that's another sort of aspect into it as well, when you come to select the tool that you want to use in practice.
Okay. I like that. There's a lot to unpack there. So I actually have seen such varied use of the pressure algometer, even in, sorry, Tinky, my little dog. We all have them. Of the pressure algometer specifically, where results are varied. So even though it has tested positively for reliability and repeatability and all the things, whenever it's used in research, there's always questions around whether that was good enough at the end of the research paper. And then I wonder, or I don't know if you've seen that as well, but I feel like every pressure paper I've read, it's kind of been, was that good enough? Yes. Or was it enough?
And have you looked at the actual absolute values coming out of the use of the pressure ergometer as well. So it's measured in newtons per kilogram. So I really am sounding like I'm a bit deep into this, but it is my specialist topic. So when you apply your force, so it's the actual force that you apply per the surface area that you're putting it. It's usually 1 centimeter squared, you know, that little rubber tip on the end of it. And so what you do usually to reduce your bias is you turn the dial away from you and you press it. But then when do you decide when to stop pressing? So that, I think, is where the variance comes. So if you are subtle, you can press and you can feel when there's a change in tone underneath the tip of that. And some people stop there because they think, well, if I'm pressing anymore, and actually those apaxial muscles are going into a spasm because I'm actually creating that reflex contraction or inducing pain, it's a testing of that mechanical nociceptive threshold after all, then, you know, do I stop there? Or do I wait till the horse's ears go back and it looks at me? Or do I wait until it moves away from me? And that, I think, is where the variance comes with it. So if you're using it and you're using it in clinical practice and you set the threshold, your own threshold, as where those behavioral markers tell you when to stop pressing, then that's absolutely fine. But then you can't compare the papers. You know, you can't look at, we've got some on sacroiliac dysfunction, we've got those on the chiropractic manipulations, we've got the ones on the tail pull tests. You know, all of those, they use pressure ergometers, but they will have all used a different threshold to decide when, you know, that level has been reached. So it is challenging, you're right.
Is it something that you use in your practice?
Not in practice. No, we don't use it in practice. We've used it for a few studies, but to me, it doesn't replicate what I'm looking for when I'm using a palpation as part of my assessment.
Okay, you do have a palpation scoring system.
I do, yes. That was well set up.
It wasn't intentional, but I love it. I actually think the palpation scoring system was one of the first outcome measures that I came across in the research that I was like, yes, this is the one.
Yeah.
So tell us about that. How does that work? And do you use that in practice?
Yes, yeah, we do. So when you look back at some of the older papers, there's a paper by Varco Cox. Gosh, it's probably a while old now, and they looked at using a scoring system to identify sacroiliac dysfunction in horses. So one of my students a few years ago came to me and said, well, could we apply it to sort of a general palpation across the horse? And it was like, wow, you know, that's a really, really good idea. So we ran with it. And so we wanted to try and really sort of relate it to what as you call it, gold standard or not, but the pressure ergometer. And we had access to these little pressure force sensors that are made by TechScan, and they are super cool. So pressure ergometer, you press down on it, the force meter you put on, and then it's between your finger and the tissues, and you press on it. And then obviously we used our hands, and we looked at the intra and the inter-rater reliability of those. And during our pilot studies, we devised this slightly modified palpation score. The other score that's been used quite a lot is the modified Ashworth scale, but that's, for my mind, is a bit more of a measure of tone during range of motion, because it comes from measuring spasticity in human patients. So it talks about the sort of catch and the give, and then the sort of the tension in the muscles, whereas what we are measuring when we do palpation is obviously the change in the muscle tone as we apply the pressure, but also the behavioral response from it. So we came up with the scale, and it actually measured really well from a reliability point of view. And we've done a number of studies that we haven't actually published, but we've looked at in horses with pain or known diagnoses of pain, and those without. And also we've really, well, I'm obviously a bit biased, but I've integrated it in our teaching at Hartbury now. So I think a lot of our practitioners now, when they document their palpation findings, they will score as they go along. There's some papers that are coming out that are under review at the moment that have used it as part of another trial, which I know you'll be interested in, but I can't share that at the moment. But what we did is we actually, the superficial musculature, we gave a score for each of the muscles. So I palpated them and I would say, splenius 3, upper portion of brachiocephalic 4, lower portion 3, and I'd go through each of the muscles and then we looked at changes of it. So the scoring system for that is it's a 0 to 5 scale, so 6 categories, and we go from sort of low tone to that normal tone is a 1. Then 2, you would feel that real sort of density, non-elastic, I won't say dead, that's the wrong word, but real sort of dull tissue. And then you go 3, 4 and 5 where you've got mild, moderate and severe of the hypertonicity, and then sort of escalating pain responses as well. And it's quite good because it just gives people a comparison, and our clinical educators now use it. And so I think it is becoming sort of more widespread that I've seen it in other institutions as well that I external examine for. And that's brilliant because your sort of research that you do in your institution, when you see it get out into clinical practice, that's when it gets, really worthwhile.
That's exciting. So Julie asks, is that scale available? And I'm assuming, Julie, you're asking about the palpation scale. Let's assume that. Yes.
Yeah, it's absolutely available. I mean, I can send you a copy of the table, now if you want to share it, or you've got it in the paper, have you? But yeah, just share that.
Yeah, one. I think I wrote a blog on it because I was very excited about it. So I'll share that with you guys in the links. I am not taking notes of all the papers I should be sharing. I have a long list of papers referenced for this discussion, and some of the ones we've already discussed are not on that list. So I will add them on for you guys. Okay, so the palpation scoring system, I love it. And then you're talking about taking that onto like a graph of the horse, essentially, of the superficial
body
muscle.
chart. Yeah.
A body chart,
yeah. So when I do my assessments, I will go through all the superficial musculature and I break it down. So say, longissimus, obviously you've got cervical, thoracic and lumbar portions of it, but I'll break down the areas that I can palpate and then score that, or even localize. So you could say, lateral to T17, that was where there was a small area of a 4 out of 5. And then when you implement your treatment, arguably there is still subjective bias to it, but you're looking to say, well, has it changed? Is that still the same response? And now I can document it that it's either a 3 or, maybe it's perfect. I've treated it and it's gone away and it's now normal. So it's now a 1. But we can start to actually use the outcome measures to sort of direct our treatment choices as well, because that if you've got a 2 out of 5, if you've got that muscle that is non-elastic, and perhaps you've also found that you've got a reduced range of motion, you might use completely different treatment approaches. Then you've got a 5 out of 5 where it's got severe hypertonicity and a pain response, that actually, jumping up and down on it with manual therapy is not going to be the right thing to do, or getting that horse, under sort of advanced exercises at that stage. So, you've got that ability then to use the outcome measure as a guidance for you.
Okay, so the palpation score is like a very specific outcome measure. We're looking at one thing, but a lot of times we're looking at the horse as a whole, and we can't always pinpoint one thing that we have to measure, right? So it's not always relevant for us to have the goniometer measurement of the fetlock of the right front leg. That isn't always relevant. Okay?
Right.
So one of the things that have been coming out in your research is essentially composite scales, where we're looking at the whole horse and looking at multiple different things, which sounds like our evaluation. This is how we're doing an evaluation, and we're looking at X, Y, and Z, and essentially ticking all the boxes. So you did an equine musculoskeletal rehabilitation outcome score, Imros? Can you tell us a little bit about that? Because I think that was essentially you just gathered information from a lot of experts in the field. What are they looking at? What is important as a way to develop that composite scale for us?
Yeah, but that's exactly right. We do want to measure everything, don't we? But we need to know that everything is relevant. And what I wanted to know, I've been working in practice for a while and developed my own ideas about things. But actually, the development of TEMROS is quite what we call inductive to start with. So I reached out to anybody that wanted to join in. So we have vets and therapists of different disciplines actually tell me what they measure and what they think is absolutely key, what is important to them. So a real hark back to some of my human physiotherapy studies where we used to have the must, should, could as part of our evaluation list. So every assessment, I asked what must it include and what could it include, and if you have extra time, what else could you do? And it was quite clear that the respondents had very strong views as to what they should use. Unfortunately, based on some of the previous research that I did, a lot of their suggestions were very subjective. So I know that, goodness me, what's the date on the paper, 2020? But, I wrote it, I probably started this part of the study maybe nearly 10 years ago. And at that time, some of the things they wanted to measure had absolutely no way that we could measure them in the field. What's really exciting now is I look back on the 10 key elements, and actually we have now started to get the ability to measure those objectively. And so now they can sort of feed into this composite score to make it as valid as it possibly can be.
I love that. Okay, I love that. So let's talk a little bit about gait assessment and movement assessment, because I think that's a really big area. And a really big area where there are such big holes. Gait assessment is incredibly subjective. We know that it's not very reliable, or between people, especially between professionals. Yes, so there has been some work in this area. Can you tell us a little bit more about gait assessment, where it's going, how we can improve that? Because we're also not just looking at or for lameness. We're really looking at the quality of the movement, the posture, the ability to perform higher level athletic tasks. All of those come into play, and they're not lameness. It's not a lameness assessment. That isn't enough, right? Let's talk about that.
You've basically just described the challenge of trying to document basically a qualitative, it's not even a tangible outcome, is it? It's the quality, and this is what we've been sort of chasing, this dream of trying to be able to do this for quite a long time. So you've already highlighted that the assessment of gait is very subjective, and it is pretty poor inter-rater reliability, and especially in the area that we tend to work in, because yes, if a horse is in front of us and it is very lame, that's obvious. You can pick a leg and you can say that's severely lame. But when we're looking at these mild levels of lameness, and when we've got this complexity of this idea that horses all have asymmetry of some extent or not, what stage does that asymmetry become clinically relevant? And at what stage is that asymmetry not our job anymore? When does that horse, should it be referred back to the vet? So it's quite a complex area. So from the pure asymmetry measurement point of view, we are so lucky now because technology has advanced. And you mentioned IMUs earlier, and I started my sort of research journey where we had gait labs, and then we had these IMUs, and you can stick them on horses and you can actually do that in the field, but it still needs a laptop, it still needs quite a lot of setting up. And I'm sure loads of you are familiar now that we've got this markerless system now that uses AI, the SLAPE AI system, and that is absolutely brilliant. It is brilliant. However, all it does is measure asymmetry between your pelvic limbs and between your forelimbs. So it is useful as a measure of difference between either the impact or the push-off lameness. But for us, I think it is still quite reductionist. So it's part of my assessment, but is not my only assessment. So where do we go from there? And we picked up on some of Sue Dyson, Dr. Dyson's research that she published. And again, this was sort of 20 years ago. You know, she's been talking about this for a while. And her score is 0 to 8. And it's on different surfaces. So she'll score 0 to 8, say on soft surface, on hard surface, in a straight line, on a circle. She'll even score it in a walk. But in her discussion of this, she says that each of those needs to have subjective comments aligned with it. So we were interested in, well, what were these subjective comments? What are we looking for? So the first study that I've been involved in was with one of my lovely students called Anna, and she looked at the breadth of what physiotherapists assess when they're looking at a horse moving. So we had some videos, and she asked them what they were looking at. So yes, they're looking for symmetry, but you then get this huge list of other things that they're looking at. So she did a qualitative analysis of interviews, focus groups, of where she looked at what they were all saying they were looking at. And they were looking at ribs, they were looking at tubercoxy movement, they were looking at tail movement, head movement. You know, just the list was, you know, really quite long. So they were looking from behind, from in front, and from the side. And it was sort of an exploratory survey, really, or sort of exploratory study to get us thinking, you know, what are we looking for when we're looking at gait? And then that baton passed to my PhD candidate, who's now completed her PhD, Dr. Annette Bowen, and she was looking at how we could score all these factors that we're looking at. So her stages of her PhD have been fascinating because they've taken this idea of thinking about the scoring of function, creating a functional scoring scale, which I think, you know, that's going to be my next push for everybody to integrate into their practice, and applied it to different movements during our gait assessment. So we can now use that and the scores and the examples that she's talked about, you know, what we're thinking is like optimal movement, what's good function, where there might be, you know, dysfunctions of various levels, to give us an idea of being able to compare, you know, it's one horse to an assessment to its next assessment, but also one horse to another horse, and really trying to help us as practitioners get a little bit more detailed than, oh, it looked okay, or, oh, it's just got a little bit of lameness. So, you know, her entire PhD is based on this scoring of functional movement from a sort of a real practical applied point of view.
I love that you mentioned that, because we did cover Annette's research on the equine quality of motion score. I can't remember, EQOMS, earlier in the year. And then I reached out to her, and I was very excited because it is practical. You're already doing most of the stuff in there. It's just a way to score it. The focus was a lot on really how do we make this applicable to clinical practice. So I really love that. And I asked her to create a little course because it's good to be trained in using new tools. And this is definitely not just a point and click tool. So she did, and she shared that with me this week. She was like, it's done, it's out, it's there. So I'm gonna share the link to that course with you guys because I'm very excited about it. I really think this is a great outcome measure. It's gonna be applicable to every single patient you see, basically, except the really high levels of lameness, because yes, then it's a different case, but it's going to be applicable to most of the cases we see. It's really valuable, and she's given our members a 20% discount on that, which is huge. So I'll share that with you guys. Okay, so moving on from like gait assessment, which I think is actually one of the biggest areas.
Yeah, I'd agree with you. I think for me, the challenge with gait is to understand that delineation between what is functionally normal, I should say, what the horse has got the capacity to cope with in its job role that it's doing, and where that tips over to it then becoming more of a clinical issue for it. And I think if we get better at acknowledging that, I think we're probably going to pick up a lot of problems earlier on. I certainly deal with quite a lot of sport horses. I've got horses of all different disciplines and at different levels. And my role, I see it, is actually doing the screening for the owner and, you know, on behalf of the vet as well, to actually identify that, you know, this horse is coping fine, it's coping fine. Actually now we need to do something about it, because not all asymmetries are pain related and not all need something done about them. But if, you know, you want your horse to be able to move equally left and right, it's got to, you know, you look at some of these 5-star event horses, what they have to do, they have to jump and turn, or they then have to go and perform, you know, their dressage tests and show jumps. So all of the very sort of technical functional details we need to be able to address with our assessment. And I think, as I said, you know, just the lameness scale is a little bit reductionist, and I'm not suggesting that that's all vets look at, but I think we're specialists in doing that, and we get the time with our patients to do that. And we might be on a sort of routine maintenance cycle with these horses, that we're going to see them, you know, in the season. I see some of mine every 3 weeks or before and after competitions. And if I'm objective, I can then be very accurate in identifying when we've got problems or not. And I think that for me is the real the love of my job, I think, rather than just going in and saying, yeah, lame, it's got to stop. It's actually the minutiae, those details to do with function that we're specialists in doing.
I like that. Do you ever create like a little outcome measure for a specific patient? You do? What does that?
It's called the patient-specific functional scale, and that's
it has a name.
Yes, it's not mine. It's not mine. I'm not taking credit for that. It's come from human medicine.
Okay, tell me about that.
So when you're assessing a human patient, obviously you set your goals and your expectations for your intervention outcomes based on the patient in front of you. So it might be that it's a grandparent that wants to be able to pick their child up, or it might be a runner that wants to move from 5 miles to 10 miles. So there isn't a scoring system for that. But then what you do is you say, you know, what is the problem? You identify your problem, and then you ask them on a score of 0 to 10, how much is that affecting them? And it's, you know, a visual analog scale. And then you do your intervention, and hopefully you've moved them in the right direction towards achieving their goal. So this is the same with our animal patients, be it small animal or equine. We are really looking for that individual to have their own requirement for treatment. You know, we're not all, you know, they're not all 5-star eventers, but, you know, maybe we've got our horse that their owner absolutely loves going out twice a week for a walk, you know, on a hack, on a trail ride. And our job is to support that patient achieving that function. So that's when we would say that, you know, that outcome measure is functionally specific to that individual. So yeah, that it's out there, and that as a tool is reliable, because you're asking the same person. It's like, how much pain are you in? You say, well, you know, how much is your, you know, how close are you to the goal? Or, you know, how much is your function affected? So yeah, that's available. Yeah, we need to use those.
What is it? What is it called again?
The patient-specific functional scale.
Patient-specific functional scale. I love that. I saw someone do something similar, probably about a year ago. And I was very interested. So my very next patient was a kissing spine patient with really bad behavioral issues. They were basically going back to the very, very foundation of working with her. Yeah. And I was like, okay, well, we need some way of measuring whether or not we're making progress. And so I created one for her, and I broke it down into like basic handling. Can you walk into her stable? If you walk into her stable, Does she pin her ears? Does she turn away? Does she do that? And that's based on like the pain. We have pain scales that look at behavior within the stable. So I graded it according to that. And then all the things. So can you lead her? When you lead her, does she da 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 da? And then the grading system worked accordingly. And it was all based on the goals that the owners had. These are the challenges that they're facing. We're working on improving them. Are we moving the marker in those areas? And I loved it. And it was so nice to use. And we would just all sit together once a month and go, okay, what is the score now in each of these areas? And it was great. So I actually really like that. Yeah.
Absolutely. And actually, one of the things that we've been focusing on very heavily is our physical outcome measures. And you've just mentioned there our pain measures as well. So we've got such as depth now and research into our behavioural measures in terms of the use of ethogram. So our facial expressions, our equine pain face, our ridden pain behaviour. We've got discomfort scales. There's one just been published on colic. There's one also on orthopedic pain, osteoarthritis in horses, and measuring things like, lying down, stiffnesses, their behaviour and whether they're needing pain relief and things like that. There's a whole wealth of them that have already been developed. I mean, Anne, you sounded like you had a lot of fun developing your own, but there are those out there already. And even if there's not one that's specific for what you're looking at, so for instance, there isn't a behavior on the lunge scale, but we could modify, quite rationally modify the ridden horse pain ethogram. Okay, we haven't validated, we don't know which parts of it are excluded, but the horse will still show those facial expressions with discomfort. They'll still change their gait, they'll speed up, they'll slow down, their head position will be altered. The extreme behaviors, the bucking, rearing, or disuniting and canter, all of those. So you could use that score and you can mark off and actually say, oh well, in this lunging session today the horse disunited, but I've treated it, and now in canter it's not disuniting. Well, that you're going to think that's an improvement. So those are validated outcome measures as well that we can apply to where the situation that we want to put them in. We can't use it for research because it's not yet validated, but for clinical practice it's really practical and it makes sense.
It makes sense. So, and the best way to, the only way we can really do that is when we are super familiar with all the different ways we could be measuring our outcomes. So the more time we spend learning the different outcome measures and then using them and exploring them, the better we're going to be at applying it to the specific patient in front of us. One of the papers that you sent me today, you asked that question, how do you choose what the most appropriate outcome measure is for the case in front of you? Can you give us some criteria on that? Like, how do you choose what to use for the person in front of you, the case in front of you?
Okay. Well, that's quite a broad question. Let's say, so if we've got we're assessing our horse, unless there's a reason why we can't. So for every single patient, I will evaluate their gait. So, those are the ones that use, and then palpation. But you mentioned, would you measure right fetlock flexion if it wasn't a problem? Well, no, I wouldn't. However, if I was looking at a horse that had an accessory carpal fracture, I might want to actually document carpal flexion. I might also think about measuring swelling as well. So you can do circumference measures in horses as much as you can in dogs as well. If we've got a horse that has, say, our kissing spine patient and they have got a pactal muscle atrophy, then I can use my FlexiCurve ruler. I think the rule of thumb really is to probably identify 2 or 3 areas of concern, areas that you want to work on as part of your treatment plan. So long as your assessment is structured well and you've got a problem list and then you've got goals and then a treatment plan, each of those goals, if you want to get really particular, should have a SMART goal attached to it, and the M for that is measurable. So specific and measurable. So then you use that as you go through each of your assessments. some of them you wouldn't necessarily assess, day by day. So we're not going to think that our muscle dimensions are going to change, 1 week from the next week. We might think, okay, well, we're going to measure that monthly, for instance. But if I was looking at range of motion, I'd want to see that change a little bit more quicker. So I would then perhaps, choose my reassessment interval as well, based on the actual tool that I've selected for that particular individual.
Okay, I really like that. Thank you so much. Guys, it's been so much fun to chat with you guys and to chat with Gillian. It's always really great to talk to you. And I think this is such a good topic for us to really sink our teeth into. There's actually so much more that we can talk about, but I will, between Gillian and myself, we will share the articles that we've referenced. I might not have access to all of them, or I might not be able to find all of them, and then I'll ask for some help.
Okay.
But I think I have most of them, so I'll share that with you guys afterwards. If our listeners want to learn more from you, Gillian, in this area, where would you like them to find you?
Probably easiest on social media. Go on Facebook. So Gillian Tabor, Equine, Physio and Rehab, or Instagram, it's Dr. Gillian Tabor Physio. If you've got some research projects, or if you want supervision, or anybody out there is looking to do a PhD, you can come and join us at Hartpury. My email there is gillian.tabor@hartpury, which is HARTPURY.ac.uk. So if you want sort of a more formal responses, then you can get me there, and we can have a real serious nerdy discussion about outcome measures.
It's always good when we can let the nerds out.
Yay!
Awesome, guys. Have a wonderful day. Thank you so much.
Thank you very much.